So essentially, this week's content revolves around capacity management. We have some process fundamentals. And then constraint management is closely connected with the idea of capacities and the idea of processes. Then we discuss operations and job scheduling that one has to do within healthcare. And then finally, different types of sequencing rules and the efficacy of these sequencing rules, which ones work better in what conditions, those kind of things were discussed in the video, as well as a web content that was created for the sequencing rules. So you may have taken a look at it. If not, you'll see that we have a problem about scheduling and different types of schedules that you can have and how good one approach is versus the other. So starting with capacity. I mean, today we know that with the current situation of COVID, we are clearly having capacity at the front and center of much of the discussion that's happening in healthcare. There is obviously a lack of capacity, and this is sort of an unprecedented circumstance for which a planned risk mitigated approach may not have even worked out. But the question then comes to how the existing capacity can be deployed for the current circumstances. So when we think about capacity at the very fundamental level, we need to understand essentially it's the throughput or the number of units that a facility can hold or process. Right? In healthcare, it's mostly about processing certain activities. It determines our fixed cost. It determines if demand will be satisfied or not. And typically when we are managing capacity, we look at it across multiple planning horizons. There's a long-term planning horizon where the options could be more in the area of modifying capacity. We can add facilities. We can add long lead time equipment. And for example, X-ray equipment, if that is something which is in short supply within the set of resources that a healthcare system might have. So we see this adding facilities has been one thing which has been going on in, at least in the US health system. Most of the health system has been growing in terms of adding capacity, critical care units, for example. And many times people question whether that level of capacity is even needed, or are we really utilizing this capacity effectively. So when we start thinking about utilization of existing capacity, we start getting into what we call intermediate or short range capacity planning. So here we are not really adding any new capacity. We are typically using resources like personnel. We're using inventories in many cases, equipment. We add shifts. So that way we are planning with the existing resources. And in short term, we are scheduling jobs and we are scheduling personnel. So that's why, I mean, we talk about scheduling within the rubric of capacity management because it's part of the short range capacity planning. Now, some terminologies that are important. There's a design capacity, which is typically the theoretical maximum that you can obtain from a given system. If a healthcare system has set up a new facility, there is a theoretical maximum that they're expecting from it. But we know that there are contingencies and constraints in every circumstance that we have within health systems and healthcare. So typically the actual capacity is always less than that design capacity. And that's called the effective capacity. So this distinguishes what the design level capacity was, and that is a maximum level, and then what is the actual or effective capacity. It's not really the actual output, but effective capacity given the constraints. So with that, if we were to determine what utilization is, it uses design capacity as its denominator with actual output, whether it's the output in terms of number of patients processed as our numerator. Whereas efficiency will use effective capacity after taking into account the constraints in its calculation. So it's just how we distinguish between the idea of utilization and the idea of efficiency. We sometimes mix them up and utilize them almost synonymously in some way, but there is slight difference between how they're operationalized. Now, the reason capacity decisions are important is because they impact several other functional areas. They are part of the operations management or supply chain management decisions, but they then have influence on many of the other activities that organization has to plan out. And therefore, it's important that these capacity decisions need to be integrated with the overall company's mission and overall strategy. So in different contexts, different types of capacity planning strategies work better. And we will discuss a little bit of this within the articles that we have also. Now, when we consider capacity decisions, obviously forecasting is one of the important step, and we will discuss forecasting in next week. But we can accurately forecast demand, then we can make these decisions on capacity in a much better way. But typically, this demand forecasting is a tricky business, and most of the time we have quite an error. So we will always be, working with an inaccurate forecast, and the capacity has to be taking into consideration the fact that we will always have error in the forecast. We match technology increments and sales volume if there are aspects of technology that needs to be accounted for as part of capacity increments. Many times capacity is more about a new technology, a new equipment, which adds to the capacity. So that needs to be considered as part of the overall capacity considerations. And then there's an optimal operating size that works best for a certain system. For some contexts, as you keep on expanding the size of the capacity, at a certain point in time, you start losing the economies of scale. Typically, capacity increases are because organizations believe that larger capacity allows them to gain economies of scale, but there is also this diminishing return after a certain time. So that's something which one needs to be aware of. And ideally, you want to create modular capacity, which is happening in healthcare also, where you can quickly change the configuration of a given capacity for a new requirement, something else that needs to be done with the same capacity. So it should be built for change so that it provides flexibility. Okay, so some tactics, staffing changes and adjusting equipment, improving processes. That's a way that we will look at in lean systems also, that many times you don't have to invest anything in terms of equipment or additional fixed asset. Instead, what needs to be done is to eliminate some waste that exists in processes, and that increases throughput. So that's sometimes a more useful direction to take, and companies find that a productive way of increasing capacity. Then you can redesign services or products that allows you to have higher throughput, adding process flexibility, and sometimes closing facilities to match capacity with demand if there's no demand for it. Typically, we manage demand by appointments, reservations within healthcare, and a bunch of discussion that we will have later about advanced access really deals with this idea of appointments and reservations. How do we manage those things within healthcare? And then capacity management using full-time, temporary, part-time, semi-skilled workforce at times when capacity is not fulfilling the requirements of demand. All right, so that's part of the capacity management broad discussion, and generally just framing capacity as how it works and what exactly different terms are, and what are the key considerations for that. We segue from there to this idea of constraint management, closely connected with this idea of capacity. Because typically when we are managing capacity, we have certain resources that act as constraints. These are the bottleneck resources. And the theory of constraints, which is foundational, has been established a long time back and has been used quite effectively in manufacturing. Now very well used also in healthcare and services. Says that normally when you're trying to increase capacity or manage capacity, one needs to look for the bottleneck within the system, because that's the limiting factor for the outputs that are generated from the system. And if you can really manage that particular resource, then it can actually improve the entire capacity, the entire system's capacity. And that's why it becomes a useful tool to have a focused thinking of which resource is the bottleneck or constraint and how can we manage it so that the entire system's capacity can be improved. So any process, we can map it like what we discussed in the last week using one of those process flow charts or any of those other techniques. Once we have an understanding of how the process flows, we can also determine how much time it takes at every process step. And bottleneck would be the step which takes the longest time. In other words, it's the slowest workstation in any given system. And so normally we try to look for, first of all, identify that particular bottleneck resource. And then what we are looking for is to eliminate that bottleneck. I mean, we can never eliminate bottleneck from the system, but that particular bottleneck, we want to address it and then keep looking for where the bottleneck has shifted. For instance, if we take this figure here, we can see here that B, which takes 4 minutes for every unit to be processed, is the bottleneck. So clearly that's the one which we want to focus on and improve. And the way we improve it is by the steps that we talked about, whether it's process improvement at B, whether it is adding an additional resource, another person who can be working at point B, so that when there are two equally skilled people managing B, then this particular process will be able to get things out. Units will take about 2 minutes for every unit to come out because there'll be two of them. So it'll double the capacity at B. And then suddenly what will happen is the bottleneck has shifted to C because C now has 3 minutes per unit. So that instance is important to recognize and understand which resource has become bottleneck once you have addressed existing bottlenecks. So that's the idea, and a lot more elaboration is there in the video that I have uploaded there. And this is an example problem that has been discussed, where we have two parallel processes and set of processes, and then we have a serial process. And the approach that we took there was to first understand what would be the cycle time for these two parallel set of processes. So station 1, 2, and 3, and then station 1 here. When they are in, actually should have been called a different number, 4. Let's say 1, 2, 3, and 4. And this should be 5 and 6. So these two parallel processes, if you want to understand how long will it take for something to get processed and come out of this parallel processes towards the sequential steps, all we need to do is identify which of these processes or workstation is our bottleneck. And that will be the cycle time, a definition which is also provided in the video. Cycle time essentially is what is the time difference between two consecutive units that will come out of this point. So if we are processing patients, for instance, there's a wait time, and then the patients will go to the next station here. So there is a frequency within which patients are moving from here to the next step. And what we are interested in is the average time between two patients moving from this spot to station number, let's call it 5 here. And that time difference between two consecutive patients is something which we can determine simply by looking at the bottleneck resource in this set, which is, in this case, station 2, 20 minutes. So every consecutive patient who will be moving out of here will be about 20 minutes apart from each other to the station. So that's something which is a sequence of steps that we go through in the problem that we solve in one of the videos. So please take a look at that. Now, once they come here, then they go through the serial set of processes. So we know that none of these have higher time than the existing bottleneck that we have chosen. So overall, we understand that this is the bottleneck for the entire system. And one of the approaches that we just talked about was to add resources. So if we were to add resource for station 2, such that we have another person. So the station 2 prime is just to emphasize that station 2 has now 2 resources, 2 people managing it. So instead of 20 minutes, it has become 10 minutes of time it takes. So we know that the bottleneck has shifted, and that's something which is a process step that we can take to improve capacity. So there are several definitions that I have provided as part of process fundamentals, and cycle time happens to be one of them. There are other things like throughput, there's lead time, and other capacity utilization. So there is a set of definitions which is important to keep in mind, because many times we use these definitions quite interchangeably. Like I was saying earlier about design capacity or efficiency and utilization. We also use terms like throughput and cycle time many times interchangeably, and they are not really the same thing. So if we understand what they mean, then it's easy to really identify, what the system is doing and how we can improve it. All right, so at this stage, I'll open it up for any questions, any clarifications so far. Everything looks all right so far? Anything that is not clear at this point in time?
I think we're good.
Okay. All right, so please feel free to make it more like conversation. I know that I've been speaking quite a bit with all these content that we have here, but if there is anything that seems unclear, just interject and let me know, and I'll stop and we can discuss that for a little longer time. So that's the idea of constraint management, coming from this theory of constraints, where there are steps that have been suggested which help you manage these constraints. We talked about this, identifying the constraint as the first step. We need to know which one is the bottleneck. And then we need a plan to overcome the constraint, whether it is by adding resources, whether it is by providing additional buffer for that particular constrained resource. And then we focus resources on accomplishing step 2, reduce the effects of constraints by offloading work or expanding the capability of that resource. And then once that is over, then we go back to step 1 to identify this new constraint that must have come about because we addressed the previous one. Okay, so that's the steps that we take. And normally what we do is in bottleneck, let's say if we take a typical health system, we know that the physician's time is typically the bottleneck because they are constrained on that front. So that physician's time, we know that is going to be the bottleneck. So we have to find a way to address that. And the way we do this is by working with this concept called drum, buffer, and rope, where drum essentially means the speed at which the physician is able to complete one particular of looking after one particular patient, caring for one patient on average. So it's like a speed at which the system should operate. It should be dictated by the speed at which the bottleneck resource will be operating. So that's the analogy here. That drum refers to this idea of managing the entire system at the beat of your bottleneck resource. Buffer is an analogy to having always some patients who are just waiting for the patient's time. Once the previous patient has been cared for, the next patient can go in, and there should not be any delay in that process. So you should not have that waiting time for the physician, because that would be a time lost for the entire system. So you find a way to create a buffer for the bottleneck resource to work. And the rope is essentially for the station where the patient will go after the physician's care. That should process based on the speed at which the physician has completed the care. So they should most likely reduce their speed, because they don't need to speed up for something that eventually they're going to do after the physician has completed their task. So they need to be connected with the speed of the physician's processes, the speed at which the physician is completing the acts. And that's the idea of rope, in a sense, connecting the next step with the previous step. So that's the idea which we use with this analogy of drum, buffer, and rope, because it originated in a book titled The Goal. And in that, this was emphasized by means of a trekking trip of kids going out, and then somebody who's very fast. If that person is ahead of this entire set of kids who are going through the trek, then what will happen is that that person will reach the end of the entire trekking expedition much earlier than everybody else. But the objective typically is that all of these people should be going together. So that's why this concept connects with this idea of drum, buffer, rope, because they utilize this innovative approach in that book to emphasize how it can be utilized in a simple, trekking expedition also. The second point here is lost time at a bottleneck represents lost time for the whole system. We talked about this, that it doesn't help if we improve the efficiency of something other than the bottleneck, because if the bottleneck is still working at a certain speed, in fact, by increasing the efficiency of anything else other than the bottleneck, the system actually can get even more inefficient in that process. And then that's one thing which we will always work on, that is increasing the capacity of the bottleneck resource. So that's constraint management connected with capacity and the idea of theory of constraints. Next, we shifted to sequencing rules or scheduling, which is short-term capacity management. And there are different techniques which are described in your web page. First come, first served, a very simple technique, normally utilized when you have adequate capacity for the resource. So resource is not, the capacity is not a constraint, then first come, first served works out fine, because it's a very simple technique to execute. Shortest processing time, this is when you are sequencing these tasks by starting with the job that takes the least amount of time and then go in incremental order of the time it takes for them to process. Then we have earliest due date, a different sequencing approach where the job with the earliest due date is scheduled first, followed by the next one, and so on and so forth. Slack time remaining is a technique where the job with the least amount of slack, which is a time until due date or processing time, which is scheduled first, and then others are followed after that. And finally, critical ratio. We calculate a critical ratio for every resource, which is basically looking at the processing time and the due date, the total time that it takes and the due date, and then dividing the two. So you'll see the calculations of these in a problem that we have described in the web page. For each of these different techniques, you will have a sequencing rule. And for certain measures, certain techniques work better. For example, if you want to reduce the average delay in the system, then you want to use earliest due date. If you want to increase utilization of resources, then shortest processing time. But there's no one single rule that helps with all these different measures that we will have for an organization. So typically we use elements of different types of techniques and combine them in some way, some innovative way, which we'll talk about in our articles. So that's our content for the week. Should have said week 2 here, but the content was supplemented with these articles. The first one discusses advanced access. So this is a approach that has been used is currently being used by many organizations. And I'd like to kind of open it up for some discussions by first framing it in terms of where this comes from. I mean, from traditional model to something called a carve-out model to now advanced access model. And there are some new innovations on top of it. The idea is to reduce the delay, the waiting time that exists for the patients to see the physician. Traditional model, what they used to do was they focused on meeting urgent demand now. and meeting non-urgent demand later. So in some sense, what was going on was that you were pushing much of the demand uh, to the future to preserve the capacity at present. Right? So this resulted in a short-term diversion of some of the productive time of clinicians, receptionists, and others into some non-care processes of decision-making and triage. So overall, this resulted in a mismatch of supply and demand. In the long term, there was intentionally created delays because there were reminder calls that have to be made. There was a complete list of future appointments that have to be retrieved. So all this adds to the overall uh, time that it takes for processes to be finished. So those are things which made this model relatively inefficient as a way to schedule. Then came the carve out model, which was the a model of predicting urgent demand and reserving time to meet it. So you just reserve some time for all these urgent care requirements. Once again, what this model does is also artificially increases demand and reduces supply. It sets in motion some informal system where there's a system of favors that you can always call something as urgent when it's not, and it becomes part of the overall schedule, and therefore it pushes actually urgent requirements further out. So the triage decisions become wrong because somebody who is well but comes across extremely worried gets precedence over somebody who's a stoic sick. Right? So that's the trade-off that we end up having in this situation here. So advanced access model, which now emphasizes to today's work today, so it relies on this concept of just-in-time within lean systems. Some of those ideas from there, or level loading, that also is something which we utilize here. So the key idea here is that patients calling in are offered appointment on the same day, and they are given appointment with their primary care physician. So continuity of care can be maintained. The patient demand for visits and physician capacity to schedule visits are to be balanced here. So if there is a big mismatch between supply and demand, then this system will not be effective. But occasional mismatch can be adjusted and can be managed in such systems. So one needs to be using a lot of data to understand how the demand is, what the portfolio of demand is, and how much capacity exists, and then implement this system. It typically sorts the appointment schedule by clinicians and not by clinical urgency. So urgency, which was the dominating factor in the previous two models, now does not take precedence. Instead, it's the clinician and their patients that is the way the system works. So each clinician is managing on a daily basis his or her own patient's demand for office care without regard to urgency. And sometimes the postponement of visits are made either by the patient because the patient does not have time on that day, or it could be made by the physician as a deliberate choice as a follow-up appointment. So they have to come again for follow-up on what was the care provision today. So the idea here, again, as against the traditional model, is that this protects future capacity by pulling all current work into the present, whereas the traditional model was trying to protect the current capacity by pushing everything from the current to the future. So that's the fundamental difference between the traditional model and this advanced access model. And as I was saying earlier, it needs to have a good amount of data to make it work effectively. So now I'd like some of you to comment on your existing scheduling systems and some innovations beyond advanced access, things that you do at your facilities. I mean, obviously, the current circumstance is an completely abnormal circumstance, and none of these scheduling concepts will work in this contingency. But I just wanted to see the normal approach of your scheduling vis-a-vis the kinds of models that we just talked about.
I'm sorry to clarify, you're asking how patients, by example, how patients can schedule into the system?
Yeah, so at this point in your facilities, I was curious as in any further advancements beyond what we just talked about, or something different from what we have here that you may have employed in your facilities, as in how they schedule, how the appointments are scheduled, and what are the advantages that you find, what are some challenges that you find for the systems in place.
In trying to read what you have here and recalling on the last slide, one aspect is with regards to um, a link from our physician finder tool. So if a patient is able to put in their location and what type of provider they're looking for, even preference of gender, and they can also even sort by their insurance type,
Mm-hmm.
and they can actually click on a link that allows them to schedule for the type of care that they need.
Mm-hmm.
Has some, for the organization I'm currently in, it has a little bit of clunkiness, but we're working through that and very quickly. Well, we were working through that very quickly until the current COVID-19 crisis, but it was allowing us to be able to hone it into what the patient, the consumer's preference needs were, and also align it to what their potential financial insurance product offered, so
Mm-hmm.
that they could, not necessarily. It allowed us to not have, hopefully, not allowed us to have a not so much rework and also denials in claims
Mm-hmm.
with regards to the wrong appointment and the wrong time and things of that being set up with what the patient was looking for.
How do you manage urgent care, urgent requirements, urgent needs? Is there a
Uh, well, I mean, when it's through their website, as far as just like a Google search, I'm looking for a doctor, it's a little challenging. And what we put on there is basically a disclaimer. If if this is an emergency need or something that requires immediate attention, it's either call 911. It's always the regulatory default pattern. But we've also started at a few places in our Virginia campuses where you can actually pre-schedule an urgent care visit, uh,
mm-hmm.
or uh, or what we are considering a same-day primary care visit.
Mm-hmm.
So you can say, I'm on my way, or I'd like to set up an appointment. And we actually do that also so that we can direct patients if the symptoms are low enough in acuity, we
Mm-hmm.
can actually offer a video visit.
Mm-hmm.
And so that way we direct patients that route, and they never physically have to, technically never physically have to move from where they're standing or sitting, as long as they meet certain criteria.
And is this an ambulatory care unit or is it something else?
Well, we use it for ambulatory care. However, it's not just primary care. We do have it built into a couple of, or essentially two of our urgent care centers in Richmond, Virginia. So
Mhm.
it allows us to be able to make sure that, if a patient is able to be there in 30 minutes and the waiting room isn't full of what we call walk-ins, then we actually get a heads up that that person's coming, and we try to prioritize their symptoms according to what our current demand is in the waiting room.
Mm-hmm. Mm-hmm.
But it's almost like I think it's there's the app where you can actually schedule your
Yeah.
dinner reservation. It only allows you to schedule so many people at a time.
Right, right, right. And what about those who already have their physicians? They've already decided their physicians. In those cases, do they get to come on the same day?
They can, in fact, but part of that is allowing us. So we have a template for the physician or the APCs,
Mm-hmm.
where essentially their 70-80% of their day is booked
Mm-hmm.
for prearranged visits. Therefore, at a certain point the day before, we release the remaining open visits, but
Mm-hmm.
we hold at least two visits the morning of, in case somebody does just like that, says, I feel for whatever reason I need to go see the doctor today. They can log on and if those appointments are open, they can self-register. If not, it directs them to call the office, and then we manually triage the call.
Okay. Mm-hmm.
it's not perfect, but it's better than what we used to have a year ago.
Right. Yeah. Yeah, I mean, it's an ongoing process where you just go through this and then you look at the evaluation of measures and then you determine whether things are working. And that's where the slide comes in, where once you establish any scheduling technique or method, then you need to identify the outcome of that. And some of the measures that we typically use for determining if this method is working well are demand, which is basically the number of patient calls for appointment during a day, plus the number of walk-ins, plus the number of follow-up appointments. What exactly are the measures that we have on the demand side? Then we need to know on the capacity side, some of the measures, the number of appointment slots for each clinician. Remember that in advanced access, we don't look at the urgency of the care, but we're looking at the clinician as the unit of analysis for our schedules. So number of appointment units for each clinician multiplied by number of clinicians, that's the capacity, would be a measure for advanced access to know whether we have a matched demand and capacity situation. Then there is this requirement to capture data with a panel of patients. So in a capitated primary care practice, it is typically the number of patients enrolled to that physician. So that would be your panel size. In a fee-for-service or a mixed practice, it is defined as all patients seen by a physician in the past 18 months. So that's the way you would collect data on the panel in that particular setting. And normally what has been observed is that if the panel is not overly weighted with aged and chronically ill patients, normally you will have about 0.7 to 0.8% of the panel who will call for appointment on a given day. So if, for example, you have 1,000 people, then 0.7% of that will be calling for appointment on a given day. And that's going to then tell you what would be the requirement that will be placed on the capacity, on the resources you have. So this kind of data becomes very useful when you are managing advanced access kinds of schedules, because then you know that you can expect approximately 20 appointments in a given day or whatever it is situation might be. This next measure is the third next available appointment. It's something which is widely used. It's considered because, first of all, physical examination appointment, any physical examination related appointment is always scheduled as far out as possible. So it makes sure that we are looking at an appointment for an examination which is typically one which is given at a later time than anything else. And the second idea here is that we look for the third next available appointment as against the first and second next available appointment, because the first and second sometimes may reflect just openings created by patient cancellations. So just to be sure that you have a certain performance level within your system, you look for the third next available appointment as your metric to understand how well you're working. So for example, one way to think about this is, what is the waiting time for a patient for their third next available physical examination appointment? You ideally want it to be 0 days. In some cases, it could also, depending on the circumstances, it could be 0 to 2 days. But that is one waiting time that you want to definitely keep in control using a system that you have in place. So that's the idea here of the third next available appointment. You also look for future open capacity as a measure for advanced access. Number of open appointment slots divided by total appointment slots for the next 4 weeks. What is that availability that is there for open capacity in the future? And last one is continuity of care, which is the number of total visits that are visits to the patient's personal physician, so primary care physician. How many times they were able to go to their primary care physician, because the moment the patient has to go to someone else, then you are adding one extra appointment at that very instance, because the patient most likely is going to be interested in coming back to see their personal physician again. And that adds to the unnecessary addition of an appointment. So this becomes an important metric as well. And also it's useful to look for the quality of care in terms of the continuity of care that it provides. So to make this system work, some important things to keep in mind are to balance supply and demand. Talked about this a little bit. And this has to be done in a prospective way. So demand must be measured not by looking in the past how many patients were treated, but because many times patients may have canceled or whatever the case might be. You look at it prospectively in terms of what are potentially the future demand that you might be observing, including those cancellations or the other situations. Therefore, record keeping of appointments sort by patients and follow-up of appointments sort by physicians is important in this case to have that data. You work down the backlog. So whenever such a system has to be employed, you first have to eliminate backlogs that may have resulted from the previous system in place. And that needs to be first taken out of the system. So first few weeks, months will just be spent in working down the backlog. Once that has been done, then the system starts in action, and then it works better. You reduce the number of appointment types, urgent, non-urgent, those kinds of gradations of appointment types. You don't want to create these categories. The only category that you want is that clinicians and their patients, if they want access to that clinician, they should ideally be getting it on the same day. So that's the simplicity that you're trying to generate in this system. Developing contingency plans. So certain times of the year require some specific plans because the capacity is going to run out for the demand that occurs, whether it's the flu season or it's Thanksgiving, it's back to school, whatever the case might be. So in those cases, contingency plans are needed. Reducing and shaping the demands of visit. So in ambulatory setting, total demand typically drops when patient sees their own personal clinicians. As I said earlier, you don't need another appointment for them. So that's one way you can reduce future demand for visits by allowing the patients to see their personal clinicians. Covering multiple issues in one sitting is also called max packing. So that's another way in which you can reduce demand for future visits. As Doug was saying, using telephone or technology to respond to patients' questions many times, that also helps in reducing the demand for visits. Increase the effective supply, especially of bottleneck resources. That's basically physicians' time. So transferring some of the tasks that physicians would do to others who can also do it as effectively. And sometimes supplementing primary physician's care with the care of others in the team. Could be nurses, physician assistants. And that's the idea of creating flexible workforce. So that's the article on access, advanced access. And then this article is on master surgical scheduling approach. It's a tactical planning approach for OR scheduling. And because OR typically is resource intensive, it's also extremely costly. So a lot of work has been done in the planning and scheduling of operating rooms. A strategic operating room planning and scheduling normally thinks about greater than 1 year horizon as part of its plan. So here we are really looking at the core OR resources that needs to be dimensioned. We look for OR personnel, look at instruments that needs to be put in place as part of this planning. So this is similar to this capacity planning that we were discussing earlier in the content as a long-term plan, right? So it's not intermediate, it's long-term. The tactical OR planning schedule, which runs for several weeks, is this intermediate plan, which is where your master's surgical scheduling comes into play. So here we are doing weekly OR time planning, and this time is divided over specialties or surgeons, and elective patients are assigned to these days. And then verification of whether the planned elective surgeries cause resource conflicts for the OR itself, the room itself, or subsequent departments where they have to go after the surgery, whether it's ICU or wards, or equipment that are limited availability like x-rays. So one needs to plan for these kinds of resource conflicts as part of this planning approach. Then you have offline operational OR planning and scheduling, which is typically 1 week long. So it's the rostering of OR personnel or add-on scheduling of semi-urgent surgeries So those kinds of things are done during a horizon of 1 week. Sequencing is done of surgeries to prevent critical resource conflicts. Then online is a 1 day horizon where you're monitoring and controlling the OR activities during the day. And sometimes you reschedule the surgery, sometimes you cancel it. And emergency surgeries are scheduled, and emergency OR teams are assembled if needed and dispatched to the first available operating room. So those are the kinds of, it's like a hierarchy of different OR planning and scheduling, just to set the stage for master surgical scheduling, which actually builds up on this idea of master production schedule in the manufacturing context. So in manufacturing, for a long period of time, there is this hierarchy of planning, where master production scheduling is the scheduling of the final products that company will be making. So this is similar to that, an intermediate level plan. For all these planning approaches, what you really need are data, a good amount of data, resource utilizations. You want that to be high. It should be robust against disruptions of different types. It could be disruptions which are supply related. It could be disruptions which are clinical. It could be disruptions because of people trying to skirt the system a little bit, and those kinds of robustness has to be in place for the planning to be successful. There should be alignment with planning of other departments, because there is a flow of patient after surgery to other departments. Autonomy of surgeons have to be understood and then managed well. Depending on different contexts, the autonomy of surgeons takes precedence, and in other cases, there are other factors that become more important. Then managerial workload, how much that adds to the workload or reduces workload, could be another way in which you can determine whether the planning is working. And the financial control, which you get by planning in one way or the other. So typically, at the very high level, all these different hierarchical planning can be done at a decentralized manner or a centralized manner. Decentralized would be where surgeons have the autonomy. They'll decide how the operating room should be managed and scheduled. It therefore doesn't require too much of data. It reduces managerial workload at the tactical level. But it requires intensive online operational control, because every day contingencies will happen, because surgeons will be using operating room for different needs. And if you want to increase the utilization, you need to have some online operational control on a day-to-day basis. It results in lack of coordination because of the nature that it has. It's a decentralized setting, and it has low robustness against cheating, low predictability of patient flows, and low utilization, because it's just optimization at individual surgeon level instead of the overall system level optimization. Whereas centralized planning, which is another way to do it, reduces the autonomy of surgeons, but requires substantial amount of data for this planning to work. It requires substantial workload at tactical level. Somebody will be doing this kind of planning. Requires online operational control, and good integration is possible in this case, because somebody who's centrally planning can make sure that you're planning for the OR and then making sure that that plan works well within subsequent departments. And typically this is robust against disruptions of different types that can exist. Now, what master surgical scheduling does is it tries to take the advantages of both centralized and decentralized in certain ways and mix them up. So essentially what it does, it creates a schedule of some recurrent surgery types. Now, there are certain surgeries that will happen based on the data that you have. You'll find that certain surgeries happen in a recurring basis. So these surgeries are cyclically executed, and the goal of this approach would be to optimize utilization. You also want to level the workload. You don't want peaks and valleys in amount of work which is happening as far as the OR is concerned. And you want to construct a robust schedule. So therefore, you create a schedule for this recurrent surgery types. And at the same time, you provide autonomy for the surgeons, because they can assign patients to slots based on these recurrent surgery types. So it allows you to yield a high utilization and robustness of schedules. It requires low degree of organizational effort at operational level, and it also gives you financial control. So there are some advantages. It reduces the overall kinds of disruptions or disadvantages that we saw with the decentralized or centralized settings. Hospital departments such as wards, central sterilization department, x-rays, they can easily anticipate future demands. So it reduces any slack or buffer that you are keeping in these departments, and therefore it increases their efficiency. So overall, there is a set of steps that you have to, there are steps that you have to take to actually accomplish this MSS based approach by clustering the surgery types of certain kinds. They need to be clustered together. Normally what you want is these surgeries that needs to be set up in a recurring basis should be homogeneous, either from a logistical point of view, length of stay or surgery time perspective, or from a clinical point of view, in terms of severity, case mix. So we basically want to combine those two kinds of measures to create clusters of surgery types. And the article kind of delves deeper into how these types can be created, and then how these all eventually work out with the implementation steps that involve seven different steps, starting with the scope, collecting the data. Then you plan for the capacity with several things that are described in the case in this particular article. Then you determine which are these recurrent standard case types. As I said, clustering techniques are ways in which you try to identify homogeneous surgery types. Then you construct the master surgical schedule. Execute the surgical schedule, and then because changes can be there in case mix characteristics, you may have some changes that needs continuous adaptation. So MSS typically is revised as and when it's necessary. So I'm not really going into details of the implementation step, which I'm sure once you read the article, you will be able to easily discern. It's self-explanatory in the article also. But some important considerations here are the organizational culture. Different organizations have different culture depending on their focus. So I was talking about, for example, physician autonomy could differ depending on the environment that you're working in. So for instance, specialty-based focused units like cardiac centers, orthopedic centers, these are the ones where there'll be high level of importance given to professional autonomy. Whereas if you go to a delivery-based focused unit, where it's like an ambulatory surgery center, there the focus is less on autonomy. The focus is more on timeliness of the care delivery process. So the ability to adapt MSS to these different environments, where in one environment you want to give that autonomy a little more weightage, whereas in the other one, it's the timeliness of the care which gets the higher weightage. So that's how you adapt across different environments. But understanding the fact that there are different environments with different cultural ethos is useful when one is implementing these kinds of schedules. All right, any comments on master surgical scheduling? Anyone with experience on this? I take it as no one has actually worked with the master surgical scheduling at this point in time, but hopefully, once you go through this, you might find that some of these things are similar to some of the scheduling you might be doing at the intermediate capacity planning level. Next article is about healthcare scheduling. We have discussed it in different formats, whether it's the advanced access or master surgical scheduling. Here, what this article does is it provides a lot of case studies, because the authors are from different health systems. So Geisinger, you have Mayo Clinic, you have Seattle Children's, Denver Health. So each of them have presented ways in which they have managed their schedules. And essentially, they have broadly categorized their activities under these big ideas like using technology as one way through which they have managed schedules. So you'll see that different systems have talked about things like risk stratification of patients. Using technology, they're able to do that. They are then able to create a care team staffing model. In the case of Geisinger Health System, they've used EHR and phone apps to eliminate dependence on individual diligence or memory. Doug was mentioning about the apps situation in his system as well. So a lot of examples that emphasizes how scheduling is done in these different organizations. The second broad idea is improving flow. So Kaiser Permanente, they are focusing on hospital delays or internal waits, and they collect data on waiting time, which are aimed at reducing surgery backlogs. Whereas in Seattle Children's, they're using lean principles for outpatient center. For Bellevue Clinic and Surgery Center, they have made some process improvements for operating room access. The third broad principle is to determine capacity and balance supply and demand. We did talk about this earlier also for advanced access, and that's the kind of things that they have given different examples for how they are managing or balancing their supply and demand. Redesigning of clinical care, the way the workflows are in the primary care clinic in the case of Geisinger system. So they have redesigned the office workforce. They have included the formation of multidisciplinary teams. There's a case manager in the case of Geisinger system. All these things, again, revolve around the process redesign idea that we talked about in the week 1 discussion. So it's the principle of process redesign. Then the respect for patients and families, because experiential quality is becoming as important as clinical quality. So how do you blend the clinical quality and experiential quality dimensions? So that's another overarching principle. And then identifying benchmarks and setting standards. Before a national benchmark can be looked at, organizations need to first make sure that their internal benchmarks have been established, and then it's working well within the internal standards, and then you project it to the national benchmarks. Then the article concludes with lessons learned. Some of these best practices that are coming from manufacturing actually works in most of these organizations. So this is a key statement that scheduling problems are not only solvable, but are also within reach of organizations of all types, because they are of different types in terms of the authors coming from different systems. Starting with the basics, supply and demand is the key idea here. Criteria and approaches for setting standards. So that's what I was saying, that before national standards can be met, you need to first make sure that internally you have looked and have an honest understanding of the settings, capacities, standards, and then work towards planning for variability. And finally, there are a few other things like improving access through novel approaches where technology comes into play, making sure that there is continuous improvement culture, and then leadership. That's the most important part. Everybody has mentioned that's the one which really separates out organizations that have done well versus those who have faltered. So that's, a whole lot of examples. I'm sure once you read it, you can relate it very closely with your own systems. And you know these systems better than I do, with how closely they are similar or different from your own systems. And this is the final article, which is for critical care service units and the idea of capacity management. And as I was saying earlier, that the addition of capacity sometimes is not necessary. In fact, with critical care units, it appears that in US, the capacity actually is quite a lot as against many other developed nations. And what's really needed is to effectively and efficiently use the existing capacity rather than building more. And The challenges that we are facing in critical care units today are mainly overuse of these CCUs. Many times the non-critical care patients are also put in critical care units, and therefore the capacity gets blocked. There is a care progression issue there. There is also step down from CCU. Many times that happens with critical care unit as well. You have staff shortages. The systems in place in critical care units with different systems that they have to work with. There's a lot of fragmentation and lack of integration, and that creates challenges across these different systems. And then there's an inefficient management, which is another challenge with the critical care units. So those are some big challenges. It's a recent article, so it's really talking about the current state of affairs with critical care units, and then presents some strategies to unlock value from these critical care units. First thing it says is that it should be viewed as a set of specialized services. Some services should be made available outside of CCU through the development of mobile critical care teams or vascular access teams or ventilatory support teams. So for these teams to operate, I mean, they should be first viewed as specialized services and then in some sense decentralized in their ability to offer services. The second strategy is to standardize and digitize key clinical and operational decisions. They have highlighted the need for assigning scores for non-CCU patients who are put into the CCU because there was capacity available at that time. Identify key intervention points along the patient journey, etc. here. Third broad category is improve the management of existing hospital capacity. And finally, to build flexibility and agility into the operating model. So the basic strategies that they've highlighted that can make the existing capacity to work well rather than adding additional CCUs. That's the key idea which they've mentioned.